Okay. All right, we're going to get started. My name is Joanna Cohn. I'm the director of the Institute for Global Tobacco Control here at the Johns Hopkins Bloomberg School of Public Health, and I want to welcome you to our Innovations in Tobacco Control seminar series. So today I'm very pleased to be able to introduce Dr. Payam Sheikhattari, who's an associate professor in the Department of Behavioral Sciences at Morgan State University's School of Community Health and Policy. So Dr. Sheikhattari has received his MD and his MPH from universities in Iran, and then was a postdoc fellow here at the School of Public Health around just over 10 years ago or so. His interest is in community-based participatory research, in social network theory, in nicotine dependence, and in substance use. And one of the things that we value here, it's important to note that last year, and I think even previously, Dr. Sheikhattari won the Faculty of the Year Award from the School of Community Health and Policy. Very important recognition. So he's very busy. He's PI on an NIH 5-year training program to increase diversity in the biomedical research workforce. And also, and what he's going to talk about today is his work also funded through NIH. It's a 3-year community-based participatory research program on CEAS Baltimore, and I won't say any more because he'll tell us, he and his team will tell us all about it. So, Dr. Sheikhattari, welcome.
Thank you very much, John, for that nice introduction. Good afternoon, everyone. It's a true honor. It's a great honor and pleasure to be here and represent the CEAS partnership, which you're going to learn more about it. But before starting the presentation, I would like to introduce my co-presenters that are going to co-present with me. Ms. Jomai Apata is our doctoral student at the School of Community Health and Policy, also is a research assistant working with the CEAS, and she's going to present the results of some of the phase 3 CEAS initiative intervention. And then Ms. Christine Schutzman is the research coordinator of the CEAS project, and also she has been the one who has led the effort of the curriculum development and coordination of research activities. Ms. and soon to be Dr. Sherita Henry is our doctoral student at the School of Community Health and Policy. She did a dissertation research on studying the evaluation of the Photovoice program among the middle school students. And she just defended her dissertation successfully, and she's going to graduate soon. And she will talk about that project. And Ms. Tamika Addison is our esteemed colleague and our community and youth liaison, who's actually has a very nice history of how she got involved, but she has been helping the CEAS, connecting CEAS with the youth and with the community. And last but not least is Dr. Fernando Wagner, the founding PI of the CEAS initiative, who will talk about some of the history and some of the assessment, the first assessments of the CEAS initiative. So the title of this presentation is about the partnership. Like, we're going to go over the whole story of the CBPR partnership and lessons learned and the kind of implications that it has on community-based tobacco control. So tobacco, as you all know, is a major public health problem. So the prevalence of tobacco in the US is about 20%. Almost 1 out of 4 people who experiment tobacco finally get addicted to nicotine. It's highly addictive substance. And it's a top cause of preventable deaths. And it's estimated that each year 500,000 people lose their lives as a result of using tobacco. And its primarily cause of death is lung cancer. And among minority groups, and primarily African Americans, if you combine the causes of death from murder, car accidents, drug and alcohol use, and AIDS all together, still tobacco is the leading cause of premature death among African Americans. So there are challenges that I would like to discuss before even introducing the partnership. One is like the tobacco initiative have been fairly successful, and we all know over the past few decades there has been a downward trend in tobacco use among middle class. But unfortunately, if you look at the different part of the community where they are dominated by poor and minority groups, you don't see those kind of trends. And there are some reasons documented in the literature for that. First of all, the underrepresented communities and populations are also underrepresented in research. So we don't have enough evidence about what works and what doesn't work among these groups. Politicians, usually are more engaged in the middle and higher class communities, and if you go to the communities that they have greater needs, you see less regulation, less policies, and less programs. And if you consider the burden of the problem in these communities, you agree with me that there is not enough action within these communities. And that's why community-based participatory research is relevant in this setting, because it's about real science. And when I say real science, it's about like applying the same research methodologies that we all know, but apply it to the real needs of the community, because the partnership here is very important. So you want to partner with the people from the community so that they inform you what's needed, and they inform you all along the way. And then it creates real actions. And CEAS is one of the CBPR project that stands for Communities Engaged and Advocating for Smoke-Free Environment. So in order to see what CEAS is doing in 1 minute, I invite you to watch this video.
Each year, tobacco kills more than 7,500 smokers in Maryland, and hundreds more non-smokers who die from secondhand smoke. It costs the state $2.7 billion annually to treat the sick and dying victims of tobacco, most of whom are poor and underserved. Morgan State University has partnered with 2 Baltimore communities to fight back. CEAS stands for Communities Engaged and Advocating for a Smoke-Free Environment. CEAS has served more than 1,000 smokers, achieving remarkable success in helping them to quit and stay quit. Through treatment, prevention, and policy advocacy, CEAS is empowering our partner communities to become healthier in many ways. Our miracle workers are peer motivators who have kicked their own tobacco habits and live in the communities we serve. CEAS is saving lives, saving money, empowering our youth, and changing the world. CEAS is a model for poor communities everywhere to become smoke-free and healthy.
So let's go over the history of this partnership. So this partnership soon is going to celebrate its 14th anniversary. So it started in 2002 when Johns Hopkins and Morgan State University teamed up, and they did a comprehensive community needs assessment and asset mapping. That provided a lot of data in the community, in the target community, and became a basis for important dialogue that followed in the following years. In 2006, there was some mini grant awards based on that data awarded by the Prevention Sciences Research Center at Morgan State University that actually created important actions around things that are needed to be done in those communities and resulted in a successful grant application to address tobacco among underserved population. This initiative is later called CEAS. And the purpose of this initiative was to address tobacco through doing a series of the randomized controlled trials. But the way that you do it in each phase, you stay in the community, you take lessons, and based on the results that you get, you inform the next phase. The first phase of this randomized trial was conducted in 2008, and the second phase in 2011. And in 2013, we were again successful in getting another award that collaboratively submitted with our community partners to do dissemination, implementation, integration, and sustainability research on this model. So the model is basically simple. It follows the programmatic or typical planning cycle. So we started by building important partnership with the community. We identified some of the people from the community who care about these issues. We built some alliances, some community advisory board structures, some subcommittees. And then, you know, through some collaborative actions, we did further needs assessment and asset mappings to design intervention and basically to have an idea what kind of responses and intervention we want to have. And later on, we recruited peer motivators to educate people and to work with the people who they want to change their behavior, and also to be engaged in wide range of prevention policy and treatment activities. And then later on, you know, we always are conscious about making this sustainable so that by building it into a culture of an institution and making it a routine policy. And then the good thing is, as I said, when we go through these steps, we come back again and then we start another phase and we take lessons and apply what we have learned. So the community, this partnership is overseen by a community advisory board. And I would like to ask my colleague, Dr. Fernando Wagner, the founding PI of the CIS, to talk about the community advisory board structure and the results of the preliminary assessment.
Thank you. Good afternoon. I feel like the grandfather of this grant. And in a way, I always try to think, what is my role here? Because traditionally, grandparents are used to spoil the kids, right? And they are already spoiled, so there's not much I can do. And the other job the grandparents have is tell a little bit about the story of the family. So that's what I'm going to do here. So our community advisory board started as a mechanism or as a group of people who will represent the community and help us understand what the needs were, what the preference of the community, what the challenges and what the fears of the community were. And as the community advisory board evolved, it was actually, they say, we will not be just an advisory, we will not just be an advisory board, we want to become an action board. And so they renamed themselves as a community action board. And the good thing is the same acronym, so we didn't have to change anything for the grants. So anyway, but so as this work progressed, the advisory board, and now community action board, tasked themselves as the main source for making decisions about the community. And as you can see, they were involved in all the planning process, meaning from the research questions to methods and data analysis. They were involved in the development of the project. They were involved in the implementation of each of the stages, and then in the evaluation. And to do that, there were a certain kind of rules and procedures that needed to be put together. And so, coming from academia, we said, well, we vote, and majority wins, right? That's how we do in democracy. We vote, and they say, no, actually, in this community, because we are so often pulled aside and left aside, we cannot take the privilege of letting some people be turned down, even if they are in minority. So what we need to do is discuss each of the concerns of each of the people involved in the advisory board to the point that we get to a consensus. And then we will be able to say. And so we said, no, but this is not efficient, it's not feasible. And they say, try us. And here we are, right? We learn a great deal. It's very frustrating for researchers to come and have to learn how to make decisions with people who often know more about their community than the researchers. But we know a lot deal about methodologies and data analysis and statistics. But often we have to find a way to combine our knowledge and teach each other. So in a little way, they are becoming like MPHs, and then we are becoming more community members. All right. So to do all this work, the Community Action Board decided to create subgroups or task force groups. And one was called the CCC, that's Community Connections Committee, that had to deal with all the network and relationships in the community. Then another was the ICE committee. It was the information and campaigns and education. And then that had to do with prevention and all this work. And then there was the CAN committee, which was the community assets and what? And needs assessment. So, and the CAN committee has been so helpful in designing all the research process that we have become so close. All right. You tell me when you want me to stop. Okay, so just a little bit about a story about the communities. When Tom Laviste and Dot Brown started this work in community back in 2002, the community was selected because it was very interesting for the study of health disparities, because there were one of the few communities in the United States that were most integrated, if you can call that, but they were mostly poor people, both black and white, and some of them were living together or not. But so it was a community where you didn't have the confounding that traditionally clouds research on health disparities, because we always tend to call about race causing things when it really is more the social environment that is causing those. So this was a perfect community. And so, as you can see, the communities, and the community when we started working, Southwest Baltimore, had one of the worst health profiles in the city, has been targeted by the industry, the tobacco industry, for years. And as a resource, we have a very high levels of tobacco use, and the highest sale point per capita in the city, and also for alcohol sale points. And the other community is also very close to Morgan. And when the new president came about 5 years ago, he decided he didn't want to replicate what has happened in many campuses, that the universities grow and grow and grow, but the communities diminish, diminish, and diminish. So the model that we want to develop is a model that helps communities develop as the university develops. So the first survey we did to do like a needs assessment show us one of the many indicators for health problems, that tobacco use was very prevalent. So you can see about 70% of the men and about 55% of women were smoking. And a number of the population, like more than half of the people were current smokers. And that's why one of the main problems that the community felt that needed to be addressed, among many others, but tobacco use was one of them. And that's what led us to think that this would be a good area for intervention. Then more recently, and I will just show this information, more recently we did a survey as we were transitioning between phase 2 and phase 3, and we were able to survey about 4,000 people. These were people who were in the community, but interestingly, about 80% or 70%, if I'm not wrong, actually lived in the community, were residents, but others were just visitors. And that gives us another interesting point of comparison, because now we can compare the characteristics and the tobacco use by different sides. And as you can see, males are still very high in rates of smoking. 66% of males refer to have smoked from the Southwest Baltimore community. And then we see the traditional differences that male, female. We also see differences by education. And we also see differences by residents. We saw more people in the community had like almost twice as high levels of prevalence of tobacco use.
Thank you very much.
You're welcome.
Well, thank you, Fernando. So, and as you see, you know, the foundation for that grant was like these statistics. And what we decided at the beginning in 2008 was that, okay, let's get together and find a solution for this problem. And that's why when we had our phase 1 intervention. So the phase 1 intervention was this. Through community-based participatory research, we designed two interventions. One was the standard clinical practice, which is an individual counseling between physicians and the patients. So patients want to quit, they talk to their doctors, and the doctors help them to quit. And then the other arm was the group counseling, which was like you put together a group of people, and then you facilitate that group with a nurse or a social worker as a facilitator, and then later on, you just follow up and go through the stages of change through a standardized curriculum. And so we did that, and then we gave nicotine replacement therapy, we gave incentives for attending the sessions and achieving some hallmarks, and then we followed them for 9 months. So the results that we got was there. So you can see the baseline characteristics, and then the outcome is like the 9.4% of our population were able to quit, and we didn't detect any difference between the two arms. And as you can see, we had a high level of attrition. So only 13.6% attended 6 or more sessions, and our curriculum was for 12 sessions. So this was a dilemma. But this was not that different. If you go through the literature and study the literature, you see, that's a comparable rate that you get anywhere else. But now the dilemma was how we can improve this. What are the kind of things that we haven't done? What should be done in order to improve this situation? So we started analyzing the data in collaboration with our partners and sharing the data with them. And then, we also did other things. We did some exit interviews for people who were graduating from our programs. We conducted some individual in-depth interviews with some of the key informants, the members of our boards, our partners. And then we did a few focus group discussions with people who dropped out, with people who didn't complete, as well as with people who completed the program to see what's their perspectives. And basically what they mentioned was that the clinical setting was a great deterrent, and they didn't like the clinical setting for smoking cessation. There were a lot of complaints about how they felt, and they didn't like the way it was much like treatment. And also they expressed a lot of mistrust with researchers and their past bad experiences about how researchers come and leave the community. And then the solution was that, okay, now we have data that shows that we can get a comparable result with the group counseling. So the group counseling is a lot cheaper. It's more cost effective. So we decided to invest on that. And then when you have a behavior change and a group counseling, so the idea was you can move into a community-based setting. You don't need to stay in a clinical setting. So instead of having those groups in a clinic, you can have it anywhere else in the community. And then instead of using the practitioners to facilitate and work with the community, why not recruiting some of the successful role models of the community peers who could be certified and educated on how to recruit and work with the group and help with them. And then we thought that when people come as a group, there are a lot that they can do for each other. They can help each other. So we added some elements of the peer support. And that was the foundation for the CIS Phase 2, that now it's 2 group counseling sessions with different types of incentives and with a curriculum that it's changed in a way that we have motivation enhancement and we have plans for relapse prevention. And this is Phase 1 data, and if you compare with the Phase 2, so our retention increased from 13.6% to 50.8%, and our quit rate increased from 9.4% to 24.4%. And that was the foundation for the Phase 3. In Phase 3, as I mentioned, the whole focus was, okay, how we can disseminate this, how we can adapt it to different institutional cultures. And I would like to ask Jamai Yapata, our research assistant, to talk about Phase 3.
Thank you, Dr. Sheikhattari. Good afternoon, everyone. So I'll briefly talk about Phase 3, and then we'll look at the results. So as Dr. Sheikhattari had mentioned, after the lessons learned from Phase 1 going to Phase 2, we still went back to the drawing board and came out with some modifications to the phase 2 intervention. So in phase 3, the focus was dissemination to replicate and expand the intervention. So the class is still held in the community, and we had 12 weeks of the intervention. The first 6 weeks was group counseling sessions. We had like a 2-week motivation enhancement, and then the four-week cessation classes, and then 6 weeks of relapse prevention, where there was basically like a toolkit that was adapted to individual needs. So people could choose whatever tract. We have specialized tracts, and participants could choose whatever tracts fitted, best, fitted their needs. So we had these tracts: healthy diet, physical activity, relationship management. So these are just briefly some of the outcomes we had, looking across the phases. So we can see, So we can see the quit rates from how it increased from phase 1 to phase 2. In phase 3, it kind of remained similar to phase 2. However, we had improvement in retention. That's people who attended more sessions, as you can see. Okay. So these are the baseline characteristics, again, when we compare across the phases. We had, so I'll just talk about, well, you see a phase T there. I'll just briefly mention that we had a pilot phase. So after evaluating what was done in phase 2, before the dissemination and expansion in phase 3, we decided to do like a pilot just to test the waters. And we had just 49 people, and those were the preliminary results from the pilot before we moved on to phase 3. So looking across, like I had mentioned, we can see that our quit rates kind of remained stable. However, we had an improvement in the number of sessions that were attended. So we wanted to look at the things that predicted quit rates, or the things that affected or were associated with the quit rates. And we looked at a list of indicators. And when we had controlled for Fagerstrom score, mental health, having mental health disorders, that's having anxiety, depression, or alcohol or drug abuse, we control for age, sex, education, employment. We found out that the number of sessions attended, so attending sessions, was the single most important predictor of quitting. So the more sessions you attended, the more likely you were to quit. And that was remarkable. So when we also wanted to look at the factors that predicted attendance. So what were the things that made people more likely to stay in the program, to attend more sessions? And again, we controlled for all these factors in a multivariate model. The Fagerstrom score, mental health, the same factors. When we controlled for them, we found that the phases, so the different interventions across the different phases, predicted retention or attendance. So we had, as you can see, from phase 2 compared to phase 1, they were 3.6 times more likely to attend more sessions than phase 1, and then that increased again in phase 3. We also found out that age predicted attendance, and so this is just telling us that for about, well, you have about 25 years difference, or 25 years increase in age would increase your likelihood of attending one extra session. So, so those were the things that we found. I think I'll call on. Thank you.
Yes, so as you can see, thank you, that the community-based, because the only difference between phase 1 and 2 and 3 was like using the peer motivators and community-based approach, and that was something that you can see that has changed the attendance. So this is the intervention development, and as you can see, our curriculum has become more and more sophisticated. So I would like to invite Christine Schutzman, CIS Research Coordinator, to talk about this trajectory of curriculum development.
Good morning, afternoon, wherever we are. Hi, everybody. I came to CIS originally as a consultant when they were starting the intervention in 2008, and I trained the physicians and the nurses and the social workers who were leading the sessions. And that was based on the Fresh Start curriculum, which is an American Cancer Society program that has been around since the very early 1970s. And that was the first intervention that we did. And if you look at the slide, you can see that we use that as our foundation. We built on it. We adapted it based on both the feedback from the community, the input of the Community Action Board, and also from the peer motivators who were seeing what the participants were thinking and how they were responding to what was going on in the session. So each one grew, developed. The first one was a randomized controlled trial with the two groups that we already talked about, physician or nurse. The second one was with the peer motivators, and it was still a 12-week program, but it was 6 weeks for cessation and 6 weeks for relapse prevention. And they were again randomized to either getting NRTs provided for them in the class, or using the quit line to get those NRTs, and also the monetary incentives were different for that. And then phase 3, after we worked with the peer motivators, we really took about 6 months to develop the CIS curriculum, which was looking at all of the different programs that were out there available. Many of them have the same foundations, the same questions that you look at to help people develop an effective quit plan. And we took all of those things, put our heads together, as Dr. Wagner talked about with the, coming to consensus. That's why it took 6 months to come up with a curriculum that everybody felt was really going to model what our participants needed and what would be effective for them. And so that was the T phase and phase 3. And what was different with that was we developed a toolbox so that at each session, the peer motivators, based on their experience with the people in the class, could decide, okay, this group is really very much they're still in contemplation. They're not quite ready to move forward with quitting yet. We're going to spend some more time on increasing their motivation and looking at the barriers that are preventing them from making that commitment to quit. So that was divided into 2 weeks for motivational enhancement, 4 weeks of cessation, and then the 6 weeks of relapse prevention with those life skills, which were optional. And again, the cash. So we really learned a lot from that. And then as we come to the end of our grant program and we're moving on to phase 4, I don't know how to make this slide go forward. Oh, thank you. So now we're in phase 4, and that is vastly different than what we've done before as far as how we are getting the people into our classes. Before, we would recruit word of mouth, referral from our former participants, advertising with flyers, going out to events and recruiting people. But for phase 4, we wanted to try and combine our interval surveys that we had done of the community with recruiting at the same time, because previously when we did that 3,900 people, we did the surveys of those, and yes, there's a lot of you who are smoke, okay, bye. And so this time we said, okay, we're going to survey them, find out if they smoke, use that moment, and try and use that moment to recruit them into the classes. And so that's what we did. And so we use iPad Airs. We go out to community events. We go to targeted community sites where we know that we've been invited to come in because they're recognizing a large population of smokers. And we survey them. And in that surveying of them, we give them the choice of whether they want to come into a single session class, a 4-session class based on our previous curriculum, or they just want to be a control, a self-help person. They smoke, yes, I'm interested in stopping, but I really don't want to be involved in one of your classes. So we give them a little packet that includes 2 patches and 3 pieces of nicotine gum or lozenges, a quit planner so that they can look at what the elements of a good quit plan are. And we also provide them with a list of resources in the community, and then tell them that either if they're in the control group, we'll see you in 4 months. If it's the single session, we sign them up for a single session class. And after that single session class, we say, okay, we'll see you in 4 months. Or we sign them up for the 4-session class. They come to the 4 sessions and we say, great, we'll see you in 3 months. So that our end point is pretty much the same for everybody. And it's been going very well. So far, we have surveyed 1,361 people, and out of that, 410 current smokers have been recruited into the program. The thing that happened when we were developing this phase 4 is that we got closer connected to the IGTC and talked about, you know, what you all were doing, and looked at the Monday Quit thing and thought that was great, and talked about partnering on that, and with these surveys that we were going to do, how could we partner on that? And anecdotally, what we found out was, when we agreed we were going to do this partnership, is we said, well, let's go and look at our previous data, the people who we've recruited before, and let's see what has happened, you know, if there's any trend there. And that's not my slide, so somebody else will talk about that. But anyway, so with the Monday Quit, we have partnered on that, and what we did was, in our initial survey, we randomized folks to either being in a Monday Quit site or a CO site. And the Monday Quit folks, the script for them when they're being surveyed is, when they've said they want to be recruited, we tell them then at that point in time. You know, there's some literature out there that says that people who quit on Mondays have a greater chance of stopping smoking. And so we wanted to let you know about that. And then we give them the Quit and Stay Quit Monday brochure that IGTC developed. And then again, we just treat them, you know, they go forward the same. And in their class, if they come to a single session or a 4-session class, we reinforce that message. The other trial that we did was the CO, and that was looking at, is there an impact of using carbon monoxide monitoring in increasing people recruited into a class. And this was just based on, you know, noticing that at a health fair, nobody was coming up to the table. So we go out with our carbon monoxide monitors, and we go up to people who we see are smokers, and we take their carbon monoxide, and lo and behold, they were very interested in coming into classes. So, okay, let's study this. So one of our DRPH students, that's her dissertation, is looking at that. And you look at the bottom and you can see that a CO site versus a non-CO site, that our recruitment is about 1/3 more using CO as a measure. So that's what I got. Thanks.
Thank you. Well, and this was like the CIS cessation trial. So, and CIS is more than like cessation. We have been working with the kids, and Sharita Henry has done a dissertation to study the Photovoice as a tool to mobilize kids, to educate them on tobacco, and to develop some leadership.
Thank you, Dr. Sheikhattari. Good afternoon, everyone. Good afternoon. So what is Photovoice, right? Photovoice is a participatory action research process by which community members capture images relative to social and health conditions. And specifically, they capture these images by a simple photographic technique. Based on these images, they create these rich narratives that tell a story. These narratives can be used to educate the community, to mobilize the community, to inform policy, and beyond, okay? So Photovoice is also used in the capacity of conducting community needs assessments and evaluations. Additionally, it's been utilized to ignite change on an individual as well as a population level. And so this particular research project that I conducted with a wonderful team actually evaluated the results of a Photovoice project conducted with middle school students within a particular Morgan Community Mile Middle School catchment area. And what we wanted to do, or what we really wanted to know, was whether or not this particular program, Photovoice as a summer program, could that be feasible to educate youth and allow them to learn about different community issues relevant to tobacco. And so my specific contribution was to coordinate the project from start to finish, to develop and implement the instruction curriculum that the youth were taught over the 7-week summer program, as well as to design and implement the evaluation systems, both quantitative and qualitative assessments. And so the specific research question that we wanted to ask, or I did ask rather, is can a Photovoice intervention be used as an after-school summer program to effectively educate youth and increase capacity building, specifically leadership and empowerment development among these youth? And this was specifically 5th to 8th grade students. And so this slide looks a little busy. But what it's basically saying is that from the start of the planning phase, what we wanted to do within those 2 middle school sites was to recruit 100 students from each middle school, okay, so a total of 200, but what we actually were able to recruit was 177 students. And from those students, what we did was a baseline assessment from a standardized measure of the YRBS, the CDC, and it measured tobacco knowledge, attitudes, behavior, and awareness. And from that 177, what we wanted to do based on sample size calculation was to recruit 44 students for that summer program, and 22 would be in the comparison group, whereas the other 22 would be in the Photovoice intervention program. What we actually ended up with was 26. And so as you can see, 12 were ushered, or rather randomized, into the Photovoice group, while the other 14 were randomized into the comparison group. Prior to actually beginning the program, what we did was measured the different leadership and empowerment skills specific to resiliency, communication, problem solving, critical thinking, teamwork, and at the end of that program in August, we did the same assessment in pre-test, post-test surveys. And so the exhibition was held during back-to-school night at both middle school sites in the following September. And following that particular exhibition, we lost some to follow up. And as you can see from that original 177, we actually had 154 and repeated that post-test measure of knowledge, awareness, attitudes, and behavior. And so within the program, we had 2 groups. The major differences are highlighted in purple bold. What we began with thinking is that Photovoice would be a comprehensive 7-week summer program, 2.5 hours per session. The difference with the control group was that they only were on site the first week and the last week. So if you think of it in academia, they would be considered the online students. And so the major differences is just simply the content. One received tobacco intervention and life skills development exposure, whereas the other group pretty much received information relative to physical activity and nutrition, and their final piece or deliverable was a poster, whereas Photovoice exhibition was the deliverable, and I'll share that a little bit in the next slide. And so with that being said, here are some of the descriptive analyses. So on average, the mean age was 12 years old. The sex was pretty evenly distributed, and the predominantly ethnic and racial group was African Americans, and a small cluster of Hispanic, white, and Asian and Pacific Islanders. And so this is a little bit more into the life skills training. So each week focused on a specific life skill, such as observation, leadership, critical thinking. Now, with respect to the leadership, the other life skills, there were very modest increase. But the leadership, we did hypothesize based on that effect size calculation that we wanted the leadership score to increase between 10 to 20 points, specifically with the Photovoice group. And as you can see, roughly 12 points was increased within that group. However, based on the p-value, there were no statistically significant differences, and that was mainly because of not enough power. And so there were 8 domains of knowledge that the youth focused on. Specifically with this photo, this is a photo and narrative ensemble by Akil. And what he really wanted to say was that once you start smoking in the community, it is very difficult to stop. This particular one, Deshano focused on the fact that even if you are in the community just waiting for the bus, there is someone smoking that has an impact relative to your health with secondhand smoke. Kyle was pretty much exhausted and disgusted with the fact that every time he had to walk by this store in his community, that he had to be exposed to different tobacco companies' special interests in targeting the youth with such signs like this to get them to start smoking, along with get their money. And Deshawn wanted to say that within a community, such a sign like this, even if you're not interested in tobacco, it jumps out and pulls you in to make you curious. Or if you are a smoker, pulls you right in to that store. And so Gabrielle actually not just took a photograph, she actually engaged this community member who was a former veteran who was disabled. And one of the things that was poignant about this narrative is that sometimes you are in a much difficult position to stop smoking once you start, and even with the disabilities, it's so compelling to pull you to smoke that you just don't see the importance of stopping. I thought that was interesting. And so as mentioned, the Photovoice exhibition, there were actually 2, but I'm just gonna focus on this one that was interactive during the back to school night. And so there were 2 different school sites as mentioned. For one of the school sites, there were roughly 45 attendees. The second school site had about 35 attendees. And so the youth actually engaged the community members about not just what they worked on during their summer program, but the community members wanted to know how could they get involved and help cease and work towards tobacco control prevention in their communities. And so it really was a critical dialogue that the youth were able to participate in and engage the attendees. So with respect to the qualitative evidence, so on the quantitative side, as I mentioned, there was, very modest increases and not statistically significant difference. However, with respect to the qualitative processes, we actually saw major transformations within the youth with respect to the different outcome variables. And one of the ones I just want to focus on here, even though it's major transformations across the board qualitatively, but the leadership piece. So the community members actually got to engage with these youth that participated in this project. And not just that, but during this summer project, the youth began a metamorphosis coming out of their cocoon to become independent researchers, right? So during a time period in summer where they can just be kick back, relax, doing what they do, they chose to go out in the community, capture photos, not just capture these photos, but they created rich stories, and from these stories, they were able to positively influence others. And that was a major piece for everybody involved in the project, not just the community members, but the facilitators as well.
Okay.
And I will leave you with that piece.
Thank you very much. So we're running a little behind, so I would like, with any further ado, ask our esteemed community liaison and youth liaison to talk about the youth leadership development initiatives.
Good morning, all. I know it's afternoon, but I like morning. With that being said, I do work with the youth, so I do know how to speed things up a bit. I've been given an opportunity. I started with CEAS as a peer motivator, so I was actually in the classroom giving people the support that they needed in order to quit. And from there, was in charge of getting the entertainment for our first conference together, and they trusted me and entrusted me with doing just that. So found some youth, my children and their friends, and put together monologues, some song and dance, and how do we move forward? Oh, sorry. Okay. And put together a performance that was well received by everyone in the room. So it was the thought that by getting kids to not smoke at all, it would prevent us from having to get adults to quit smoking. So it was like combating it from the other angle. Because as you can see, well, the first fact here says that tobacco use starts and becomes established primarily during adolescence. And that was the focus, to get to the youth as young as we could get them, keep them captured, and keep on moving. This is it going to play? Thank you. This is an animation that was done to show the red bullets are the tobacco outlets in the community in Southwest Baltimore. The yellow are the schools that are there. So it tells you how many tobacco outlets there are, how easily targeted the children in our communities are. So we wanted to give them a fighting chance. We wanted to give them voices. We wanted to give them opportunities to say, we do not want this to go on in our communities. And as you can see, it's very, very powerful. Our kids were given the opportunity to, after that conference, we received a grant from the Baltimore City Health Department. They said, wait a minute, you're doing this with who, where, how? And I'm like, at my house with my kids and their friends. They were like, but we have grants for stuff like that. Oh, really? So literally the Monday after our conference, we were called and told, wait a minute, there's money. Fill out these forms and here you go. We received the grants. And with that, these are my children, my nieces, nephews, cousins in the all-white t-shirts that were made for this first CEAS conference. And at that conference, like I said, they just did what they knew was natural from being around and seeing what goes on. So they got some facts, they made monologues, they did song and dance to popular songs. So the kids in the audience were literally catching on, so you could see what was happening. After we received the grants, we toured Baltimore City Public Schools, community events, and literally went out into the community and used what we did at the conference to impact our community. We had to create a youth advisory coalition and present recommendations to them from the youth standpoint, and we did just that. We were only supposed to give 7 recommendations, but we ended up giving 14. So they were looking at us like, wait a minute, hold on, wait a minute. But with that being said, our youth were given a voice. So on the day that the actual Baltimore riots started, we were actually in a session. Literally, I took everyone's phones, like, no, we're not gonna watch this, we're not gonna see what's going on, we're not gonna do that. But our youth literally used their voices to say, the difference is those youth don't have voices. Their voices aren't heard. We feel powerful because ours are. We need to do this more in the community. Give youth voices and platforms so they can get their voices heard, and adults will take them seriously because, like you already know, it was not good at all. So we participated in a Kick Butts Day campaign where we just took the CEAS whiteboard and we let each child write exactly what they wanted to write. Our message is targeted to the tobacco industry. So what they said is, we are not your replacement. We know our lives matter. You don't care that our lives matter. Stop targeting us. Every one of them. So we have 52 children that came out to participate in our Kick Butts Day campaign, and it was very successful. Sorry, I wasn't talking about what we did with the first campaign. We did reach the target as far as getting all of the recommendations to the Baltimore City Health Department as the youth coalition. We were supposed to reach 15,000 youth, and we were supposed to have 9 months to do it, but we didn't. We had 6 months, but in 6 months we reached 10,980 youth. So that lets you know, if we had 3 more months, we would have well exceeded the numbers that they gave us. This is our youth getting active. So we have youth that are working on Facebook and Instagram and Twitter, just getting involved, because you reach kids where they are, and giving kids the platform to do just that lets you see how many kids they actually target and how many kids they actually reach out to. The conference this year was well received. They did the Whip and the Nay Nay, one of the popular songs that everyone was familiar with, and literally everyone in the audience, as you can see the bottom left picture, the audience was very well engaged in what was going on. And then they said, now that we have your attention, let's give you some facts. And literally that's how they stuck. This is our youth getting their voices heard. They wear white masks when they come out, and it says a lot about what's going on, and it says, we're invisible to you. Are we invisible? Are we invisible? And they snatch the mask off and say, no, we are not invisible. And it gets everyone's attention, and it makes you focus in on what the kids are doing next. So that's when they give you everything that's going on with the facts. Okay, this year we got those grants back again. But this year we got more money to do exactly what we love to do, and that's to go out and reach more people. And instead of last year we had 25 kids in the after school program. This year we have an ability to have 60 kids in our after school program. So watch out and see what our youth are doing next. After the riots, we established doing a community hug. That's where everyone in the community came out. It was like, we're okay. We have to live here. In order to make the streets safe, we have to be in the streets. So we started having a community hug, and we had one every month from April until September. And every month something different was being done, just giving back to the community. It was free to the community. Anyone could come. Okay, anyone could come. Everyone could just come out and see what was going on and how different CEAS was. CEAS wasn't just here to get something from you. CEAS is here to give back. So people donated foods, people came out, and it was very exciting to see the community engaged in what we were doing. As you can see, that's Elvis, AKA Lightning there. This is our PSA.
I know it's killing me. There's hurting people around. I try quitting for years, and nothing works.
CEAS is here to help. We know how deadly smoking is and how hard it is to quit, but we've already helped a lot of smokers quit. CEAS is free. You don't have to do this alone. Call 410-528-5915. That's our public service announcement that we just recently did. So as you can see, CEAS is reaching the community on many levels. So watch out, wait and see what CEAS is doing next. Thank you.
Thank you, Tamika. So, and I think it's important for me to say that Tamika joined the CEAS partnership through her daughter. Her daughter was one of the participants of a Photovoice project. And then through all these years, she has been an invaluable asset connecting us to the youth and the community. So I just would like to quickly say that CEAS has been about cessation, policy development. I don't want to go over all these things, and also prevention, but it's also about sustainability and the future. In the future, we are thinking about like having this model as a blueprint as an organizational model that you can help the communities to improve their life skills through empowering the community peers to come and to get what they need in order to be able to accomplish that mission. And we have instituted some events, as Tamika mentioned, CEAS conference. We had like 2 annual CEAS conferences. One of them, the last one was on October 10. And also this year, for the first time, we had the Youth Health Sciences Conference. So we received another award. It's called Ascend, the Student Center Entrepreneurship Development Model. So, and we have trying to build a lot of synergy between that grant and the CEAS, so we help each other. And this is a partnership event that CEAS and Ascend are going to do. The first one was this year, and we're going to have it the next year again. So thank you again for your attention.
I know we're close to time, but if there are a couple of questions, let's see.
Yeah, so first of all, thank you for coming. It's so great to see such an awesome program in the community here in Baltimore. I was curious about your first 3 phases. This might be a slightly technical question, but did you guys at all evaluate self-efficacy, like of the participants who were enrolling, and if so, what timeline?
That's a very good question. So we had a baseline data that captures some of those self-efficacy things, like such as how ready you think you are. We had a readiness ruler, we had a motivation ruler. So we try to ask them like where they are when they join the program and try to help them improve while they are in the program. But there are also other ways of like in our exit interviews and the focus groups, we try to capture like some of the impacts in a more qualitative way. Yes.
Good afternoon, everybody. I didn't want to say good morning because it's still good morning. I'm Tamika's mother.
another pack of cigarettes. And I understand that it's really a complication to just stop smoking. Now with this organization here, it's a good thing that you're doing because there's a whole lot of young kids out here also smoking. You know, and I mean young. I'm 63 and I'm smoking again. But I want to stop, and I try to stop. But it's not so easy. It's good to have movies like that, and you look at it, and you know what the nicotine do to you and how it does and all that kind of stuff. But if you ever smoke, you can understand what I'm saying. I want to quit, but I can't. I might quit for like a year, and then I end up right back with the cigarettes again. I might be at a party with some friends, and I didn't stop for like maybe 6 months. Then you're around to smoke again. Can I have one of your cigarettes? You know, so it's really good that this is going on, but how do you keep people from going back to the cigarettes? That's the problem.
So I would like to ask your daughter to answer that.
With that being said, then, well, CEAS offers, after you finish our courses, we offer CEAS support. So in and around the community where we try to meet people at where they are. So we come and go into the community centers and try to have CEAS support classes, as you already know. It's difficult when we try to do relapse prevention. So a lot of times it's hard to quit, but it's easy to quit, but it's hard to stay quit. So giving people the opportunity to have that one-on-one relationship with a peer motivator, that one call away, I need this help. Some of our peer motivators actually give out their very own telephone numbers. Like they get phone calls 11, 12 o'clock at night. I need a cigarette. Oh my gosh, talk me through this, because we know it's hard. But definitely we will meet you where you are. And if you would just take these classes and give it a try, if we can get you to quit on it, I'm so glad you want to.
I know we're sort of out of time, but this was a terrific presentation, great work that you're doing. So I just want to give folks the opportunity. Are there any more questions?
Yes.
So today there was a big news story all about smoke-free public housing, and I was thinking about the potential for something that has a great potential to make it so that to change the norms around smoking, but not necessarily that would meet the community where they are. So I was wondering what's happening from a sort of community up level around smoke-free homes.
Well, I would like just to say before asking Christine to address this, the CEAS project was one of the big forces behind making Morgan State University tobacco-free. And tobacco-free policies create a very good opportunity for actions, for prevention, for treatment. And I would like to, having said that, ask Christine to.
So we have a policy committee, and we were looking into how can we support smoke-free public housing. In the meantime, it's the private contractors who are doing the public housing are really the driving force behind making this happen, and that's because it costs them less money. So we actually go to some of the Holland's House, the Allendale, and we go there, we recruit right into their building, we will hold the class right in their building, and at the same time we still do the advocacy work, the legwork on the state level, which is where it has to happen for that housing issue. We're doing that legwork through our community action board and our membership to go out anytime there's a hearing. We try and be on top of that, and there's not just one way. There's not just one road to make this happen and to support it and to help out in that situation.
Thank you. Well, thank you very much.
I just want to thank you again, Dr. Sheikhattari, and the whole team for being here and for all the great work that you're doing and for sharing it with us. Thanks very much.